Thank you, and I bring you greetings from my Department of Nephrology, Christian Medical College Vellore. And I thank the organizing team, Sudipto and his team, for giving me an opportunity to speak. For the probably next 15 or 12 minutes, less than that, I'd just like to see how we can do strategies to improve patient outcomes in dialysis, on patients on dialysis and acute pancreatitis. There's no disclosures that I have, but the brief outline of my talk would be to just give you my perspective of the two kinds of patients that probably you all will see. First is an acute pancreatitis presenting to you with an AKI, that is a severe acute pancreatitis with AKI. And the second is an acute pancreatitis in chronic dialysis patients who do come. Their clinical profile and factors predicting their outcomes, the management strategies, is it making it better for the last 2-3 decades that we have been dealing with, and to conclude with few take-home messages. Most of the points have been mentioned by the previous speakers with regard to the acute pancreatitis, its clinical presentation, the clinical course, and the severity of the illness being a very poor prognostic marker. 15 to 20% is increased goes up to 35 to 40% if there is an infected necrosis of the pancreas or a multi-organ dysfunction. One thing that has come notice is that the extra pancreatic complications also contribute to morbidity and mortality. Just as listed out here, it runs in a high percentage. And how much of that plays a role in the renal medicine is something that we all need to know, which is a tenfold increase in mortality. It's understudied. Clinical features are quite elusive when they present, especially with those who are on chronic dialysis, whereas it is a high risk when compared to the general population. The in-hospital mortality is about 8%. What we do see in the chronic dialysis patient is usually the metabolic disturbance. The other common factors that do cause acute pancreatitis, we do see in our dialysis patients, but one of the most common metabolic disturbances we see is hypercalcemia. What about the dialysis modality? Does it play a very big role in the outcomes of patients who present to you with acute pancreatitis? We see more of them, those who are on peritoneal dialysis than on hemodialysis patients. The mortality is about 50%. Now, the risk of hospital admission due to acute pancreatitis is always more than 3 times in patients on HD. And they develop severe acute pancreatitis, which is about 20% when compared to the general population. The pathophysiology has already been alluded to by all the previous speakers, the premature activation of pancreatic enzymes, causing a local injury, the necrosis leading off to a cytokine storm, which has its impact as an inflammatory cascade and on different organs. Now, when it comes to the renal, we have a very narrow window period, and I think I always felt the timing and the management are important in the early first 24 to 36 hours, where you do have a time when the cytokine storm is on its way, but subsequently after the 72 hours, you see the kidney usually gets into a shutdown, and if the severity of the hypotensive shock, not only does it cause an ischemic tubular necrosis, sometimes you can wipe it out and cause a complete cortical necrosis, wiping out the kidney, probably leaving the patient dependent on dialysis for a very long time. So my perspective of an acute pancreatitis presenting with AKI, you have 2 therapeutic interventions to tackle. One is the local regional, and the other is a systematic impact. When we look at in relation to the renal medicine, the systematic review of the literature, we have quite a very sparse data. The RCT is not powered well to see the outcomes. Most of them are observational cohorts, and those cohorts are retrospective. So when we look at, these are about 6 studies that did look at the dialysis outcome or how we can improve strategies on patients with pancreatitis on dialysis. So when you look at the few papers that came in, one was the extra pancreatic complications, another paper from the north, and this is one from the MMC Chennai. When we looked at the acute kidney injury complicating these patients, their clinical profile and positive predictors of poor outcome are quite a few. Alcohol consumption was the commonest cause, and with all the 3 studies that they looked at multiple factors of clinical factors, the type of pancreatitis that the patient presents to you with, use of the different clinical scores such as the BISAB, and Another common elutive factor, like Dr. Binila said, was the high BMI, the obesity. And for us, at the renal side, it's the stage 3 KDO classification of Akin, when the creatinine is usually more than 3 milligrams per deciliter for the last 3 days, and there is a significant trend to increase from the time of presentation. And the second criteria is usually the decrease in urine output, which is less than 15 ml per hour. One thing that do come out is the non-infectious extrapancreatic complications have a higher mortality rate when a present is added on in the ICU, which is accounting to about 3 to 17%. So what are these extrapancreatic complications, which has again all alluded to, which is ventricular-associated pneumonia, circulatory failure, acute coronary syndrome. The fact of initiation on dialysis is one of those most common factors that have been mentioned in the role of this play. The use of these different scores have also brought its significance in managing these patients while they can be initiated on dialysis. And this is what the standard classification of the AKI that has been reported in various papers that which are mentioned in our literature as well. So how do we improve outcomes? It is difficult. It's a teamwork. There's a lot of factors involved, and we are definitely getting better. And this one paper that is from AIMS, which Dr. Karg also is in our midst today, came out in 2018. You definitely see that there is the increase in admissions in acute pancreatitis. The time of presentation is usually coming late. I'm not sure how much of difference would that have been happen now 6 years from down the line, but the incidence of infective pancreatic necrosis, organ failure is increasing. When you look at the actual predicted mortality, when you see it's definitely the role of organ failure has a significant impact on the mortality, as well as the predicted mortality when you use the Apache score. When you do adjust it for the predictors, there is still some amount of a declining trend, but we have still more to do. So the decline in the mortality probably due to be a better management, less non-invasive management, better ICU care. So when it comes to renal difference, what can or what made the difference? Is the timing of the renal replacement therapy, or is it the modality that we choose to manage these patients, or is it just that we are being able to identify the high-risk individuals in where we can do an early initiation of a renal replacement therapy? So papers have now come out with different predictive models of putting in a lot of clinical factors from the bedside to the bench, and to see how we can try to manage these patients much earlier. So the review of literature of some of these articles which I pulled out in the last few years, we have about 3 that do predict about them. Going to this, how many of us will straight away go into a continuous renal replacement CRRT in patients, or shall we just do only just plain hemodialysis, conventional hemodialysis? When patients or institutes or units that do not have the facility to do CRRT, we should not get apprehensive. You can still use SLED, that is slow, sustained, low efficiency dialysis, which you can actually run it for 8 to 12 hours, which can give you equal outcomes in patients who do not have who do not have the CRRT facility. This paper actually looked into 3 models. The first model, they looked at the CRRT initiation time. Then they added another 2 more factors. They looked at the time, age, and the gender. And the third model included the above 2 factors with the type of acute pancreatitis, the Marshall score, the Apache, and other medical comorbidities like diabetes, obesity, liver disease as well. And what did they find out? They found out that the CRRT itself is an independent protective factor. It gives you a better outcomes. The Marshall score kind of tells you the risk factor or risk stratification that we can try to do. And when compared to those patients who did not have CRRT, shorter hospitalization and vasopressor duration was much less with a comparable cost. Now the time of initiation, probably this paper said less than 36 hours. So we have a window of about 24 to 36 hours, which itself showed it was an independent prognostic marker. The differences existed in the type of pancreatitis that the patients were presenting to. And the independent risk factors for the CRRT failure was actually a rising procalcitonin, the worsening of an Apache-2 scoring, and the lactate or the calcium albumin ratios were shown as a protective factors to say the CRRT will not be beneficial. Now, CRRT do remove toxins and inflammatory factors. It improves the microcirculation, stabilizes the hemodynamics of a patient who's actually hemodynamically unstable, and it also kind of corrects the internal environment disturbances for the reason for this paper to come out to say this is an ideal modality. Now, this use of the CRRT is still not being looked into prospectively, so there is still some amount of controversy around the use of it, but given what the data we have, it definitely has some benefit. Despite all this, what does these models actually tell us? Absolute indications try to do the CRRT. You have a very worsening acidosis, a worsening potassium, or a worsening creatinine, a decreasing urine output, hemodynamically unstable, hypercalcemia. These are some of the factors that you can use CRRT. Without absolute indication is where a lot of clinical decision making comes. But this model can, or probably if we do it more prospectively, can help us to individualize treatment. It needs to be validated. This was one of the olden days, another paper that came in where they were using the peritoneal lavage during the olden days, trying to remove the local. I'm not sure if these are being used today, definitely not from our side with the introduction of the catheters, trying to remove the local inflammatory molecules. But patients on peritoneal dialysis, they come with you with a very cloudy effluent, with significant pain. One of the differential diagnoses that we do think about, in addition to peritonitis due to peritoneal dialysis, is always acute pancreatitis. The timing of the admission, they always say you can do it within 3 days. So you either do the peritoneal lavage, those who are present in the AKI, and also start off with the dialysis. 6 studies had looked into it with 499 patients. They did report of saying reduction in inflammatory markers, shorter hospital stay, lower mortality, fewer secondary complications. Again, the use is still controversial because of by a lack of appropriately powered, well-performed RCTs. And there is a large variations in the way the peritoneal lavage dialysis is being delivered, which was reported in the paper. The other that came into was the prediction model of an ICU mortality. Now, this paper kind of tried to identify patients into 2 trajectories, those who have the low-risk trajectory and the high-risk trajectory, by looking at certain outcome predictors when they presented to the ICU within 24 hours. They looked at the Apache-3 score, the PF ratios, and the requirement for mechanical ventilation in the first 24 hours. They noticed that the people who required a stay of hospital more than 7 days, increased mortality was noted. Initiation of dialysis was one of the most important factors, and increased mechanical ventilation. This was actually done in the Australian, New Zealand data in the ICUs. So the sample size was not calculated. Unfortunately, the paper did not report on the incidence of pancreatic necrosis in the data set. And since it was within their country, whether it can be applied to other ICUs was still questionable. So that is the kind of patients who present you with the AKI. In my concluding slide, probably I do mention how we can initiate or try to our best to improve. But the second group is what I usually are concerned about, a chronic dialysis patients present with acute pancreatitis. They kind of have a very different presentation. They may not have the classical symptoms as you all see in acute pancreatitis with the AKI. Very limited studies of the severity of acute pancreatitis in dialysis patients. There's been no study to investigate the prognosis of these dialysis patients in the long term. So this was one, when I tried to look into this is one of the papers that came up. Most of these dialysis patients, their presentation of acute pancreatitis can be idiopathic. Peritoneal dialysis has a high risk of acute pancreatitis than HD. The mortality is almost about 50%. And hemodialysis patients with acute pancreatitis, they have a higher incidence of upper GI bleed, whereas peritoneal dialysis patients need a higher incidence of TP and support. The risk factors mainly were male, gender, old age, the severity of acute pancreatitis, and comorbidities such as diabetes and liver disease. This is one of the papers that just looked at the clinical profile. What about this paper that looked into the risk factors in etiology? This is where most of this, and we have faced this in our unit as well. Hypercalcemia present to you with an acute pancreatitis in most of our hemodialysis patients. The other factors that have been mentioned, but one factor that I do like to mention is about the PD, that is the peritoneal dialysis, where there is about 2.5 liters of volume that we install into the abdomen, which is a very high glucose content in the dialysis, which can actually trigger off activation of these pancreatic enzymes, can cause a hypertriglyceridemia, causing a local inflammatory response, triggering off the acute pancreatitis. Diagnosis is usually challenging, but one thing that we have noticed, most of these enzymes, that the amylase and lipase in the setting of CKD is difficult to interpret. It should be about 3 times higher because these enzymes are actually excreted through the urine. And with the declining in the eGFR and the progression of chronic kidney disease, these enzymes tend to be at a higher level in a patient when compared to the general population. So the management part is a little different, like how you all do the fluid resuscitation. We cannot be doing that for our dialysis patient. Very stringent fluid management. Initiation of dialysis probably early, and no specific scoring has been actually shown to be beneficial in this population. So to conclude in the few slides, improving outcomes in acute pancreatitis is urgent, unmet, still a clinical need, and in the dialysis population it is still even more. Just want to give one slide on the role of cystatin C. Most of us do not use this marker. This is a marker that is available in most of our biochemistry labs. Try to use it. The reason is cystatin C can be a biomarker. It rises before a creatinine rises. You do not need to depend on the urine output. You do not need to depend on the creatinine rise. It doesn't depend on your urine analysis to pick up a cystatin C. And most of it, when you are trying to depend on a creatinine, the limitations is you'll be missing subclinical AKI. But when you try to do a serial marker of a cystatin C, these are the definite features. It's not secreted in the urine. It doesn't depend on diet as well.
Sir, if you can conclude.
Yeah, so to conclude, the acute pancreatitis presenting with the AKI, both are significant factors for mortality. You need a risk stratification models to validate it. The best way to go forward is doing your observational cohort with the propensity scoring methods to see the benefit of treatment. And with the ESRD patients, they are elusive, different metabolics, hypercalcemia. So till then, practice medicine wisely, and thank you.